All right, everyone. Thank you for joining us today for our very exciting keynote. I have the honor of introducing our two keynote speakers, Dr. Andy Livingston and Dr. Richard Gourley. They're both very accomplished, so while I read their bios, please bear with me. So Dr. Andy Livingston is a clinician and researcher in sarcoma medical oncology and holds a joint appointment in pediatric oncology. After completing medical school at the University of Texas Medical Branch at Galveston, he went on to residency training at Duke University, where he completed a combined residency in internal medicine and pediatrics. Dr. Livingston completed his fellowship training at MD Anderson, where he served as the Chief Fellow for Hematology Oncology Fellowship Program. Dr. Livingston has a particular interest in the care of teens and young adults with cancer and is co-director of the MD Anderson Adolescent and Young Adult Oncology Program. His clinical and translational research is focused on developing new treatment strategies for patients with osteosarcoma and other bone sarcomas. Dr. Livingston's goal is to improve outcomes for adolescents and young adults with cancer through research, clinical trials, peer and programmatic support. And one of my lifelong heroes, Dr. Richard Gourley is a pediatric hematologist, oncologist in Houston, Texas at the University of Texas MD Anderson Cancer Center. He is division head and department chair of pediatrics, department chair ad interim of sarcoma medical oncology in the division of cancer medicine, and H. Grant Taylor, MD, W.W. Suto, MD, and Margaret P. Sullivan, MD, distinguished chair in pediatrics at MD Anderson. A pediatric cancer survivor himself, Dr. Gourley committed his life's work to helping young patients and their families. For more than 2 decades, his research and clinical efforts have centered on sarcomas. His early involvement in the Children's Oncology Group established the founding Bone Tumor Resource Laboratory, which has become a national resource and home to the world's largest osteosarcoma tissue bank. Dr. Gourley has served as an active member, advisor, and leader in a number of organizations, including the National Cancer Institute's Pediatric Preclinical Testing Consortium, the Sarcoma Alliance for Research Through Collaboration Consortium, and the COG. Dr. Gourley is involved in clinical trials, in part as past chair of the Bone Tumor Disease Committee for COG. He is also a past president of the Connective Tissue Oncology Society. Dr. Gourley has published more than 299 peer-reviewed papers, reviews, and book chapters. So without further ado, Dr. Andy Livingston and Dr. Richard Gourley.
So thank you very much for the opportunity to present to COCA this keynote address. Obviously, you guys have a great organization that has a great mission. Thank you, Ryan, for that exhaustive, description. I know Ryan since he was 2, and obviously he wanted to go through my entire CV from that time forward, and I appreciate that he did that. I'm also thankful to Andy Livingston, who's actually an expert on survivorship, as well as AYAs, as well as sarcoma patients. And he's going to provide a lot of the content part of the talk, like the science, and actually, talk about what's known in the field and, really, talk about from the perspective of somebody who knows that what folks face after cancer treatment. That said, it's my privilege to start off, and me, I'm going to start largely with a historical perspective. When I start with a historical perspective, it really starts, with my history of camp. So, the camp that I've been involved with the longest is really Happiness is Camping, which Ryan Campbell is part of. This is a camp that dates back to 1980, and like many, provides services for kids and their siblings with cancer, with, the goal, like many, to let kids with cancer be kids again. I have to now step back and start really talking about historical perspective on, pediatric cancer in general and camps overall. So adult cancers are different than kids' cancers. Adult cancers start as indolent lesions that, if they're caught early, can be surgically removed, and that can be the entire treatment. That's in stark contrast to cancers in kids, where they disseminate early in their natural history, and really kids in general need chemotherapy in order to be cured of the cancers that they typically get. Putting this in perspective, before the 1960s and 1970s, chemotherapy didn't exist at all. It was only invented in the period after World War II and beyond. And so when you think about the 1960s and 1970s, most of those kids, unfortunately, didn't survive their cancer. And, the focus was finding treatments that could cure them of their diseases. I think when chemotherapy got invented, it started getting applied to kids with cancer relatively early on. And for kids, overall, it was the success story of sort of early oncology in general. Kids who wouldn't have survived at all started surviving. But there was a recognition that, having the cancer experience, having the treatment, was a huge traumatic event. And, when we started looking at survivors, they were impacted heavily by, the illness and everything they faced. Very quickly, Ryan had mentioned that I am a cancer survivor. I had a synovial sarcoma as a kid. I had chemo, and that's fortunate because I survived. But to put it in perspective, I was diagnosed with cancer in 1979. Just the year before Happiness is Camping was formed. So obviously I didn't have the benefit of these type of organizations or these approaches. And some folks, were like me, were lucky and we survived and ended up turning out okay. But in general, people who survive cancer, have a hard time with the cancer experience. I couldn't find a picture dating back to my earliest days of sort of Happiness is Camping. So, the pictures on my wall date back to 2000 and 2020. The first year I went to Happiness is Camping was the first summer of my training, which was in 1997. And I started as a volunteer doc. Ultimately, when my mentor, who had been the medical director of the camp, sort of was no longer able to do that. I took over as the medical director for Happiness is Camping, and I actually stayed in that role until I departed to Houston all the way in 2016. I still remain connected to the camp as its medical director emeritus, and I still try to volunteer there. And obviously more pictures, but at the same time, obviously distance has others involved. And, obviously the board of directors is a great team like it is for many camps. One of the things I do want to talk about a little bit about Happiness is Camping is the fact that, we did go ahead and have a sleepaway camp despite COVID. This was done with a lot of careful considerations. We actually used some of the infectious disease experts at MD Anderson to help me provide recommendations. Used a lot of function around screening and testing, creating sort of pods where people don't move in and out. But I think really the point behind all this is, camp is going to come back for sure, regardless of the way sort of COVID evolves. We'll obviously have to collectively titrate things up and down. But either way, I think the future is bright, and hopefully everybody is actively planning for, a spring and summer next year. And again, this just gets at some of the things that were done to sort of manage. And obviously camp pictures don't have typically folks wearing masks, but in this particular year, it was something that was needed. Obviously they use rapid testing and all sorts of approaches for dealing with this. And this actually continues, into, these slides. But basically, we're certainly, I'm sure Ryan or others or I would be happy to share some of the strategies that worked. And really the key at the end of the day is, providing opportunities for pediatric cancer patients, siblings, and families to enjoy normalcy, because it's that period of normalcy that sort of helps people adapt and, throughout their journey, recognize there's life beyond illness, and there's others who are sharing the experience. I did want to show a couple of slides from MD Anderson. so that I sort of don't create this perception that this is something I did in my years in New York. And then as soon as I came to another place, this was something I moved beyond. You know, these are sort of the overview and purpose of camp. Again, just another way of sort of expressing what we all know, that it's sort of the normal child experience despite cancer. That is really what camp is all about. So, you know, camp isn't about, you know, cancer at camp. It's about kids who just happen to have cancer. And again, MD Anderson offers a whole host of different camps. There are, you know, some of them are in-hospital experiences, some are others, but again, same general principle of, you know, these are provided without cost, and generally donations support our operations. You know, Camp for All is an in-house camp where we do it in one of the big spaces within the hospital itself. We have a camp, which is the classic rustic teenager camp with sort of wood cabins that are high up to deal with rain in Houston, and, you know, the classic types of camp activities. We have Camp AOK, which is a little bit fancier of a camp, where, you know, it's what I wish camp would have been, you know, in a sort of more elaborate facility. And us, like exists in some other cities, the Four Seasons Hotel sponsors a camp that's even fancier than a less rustic camp, and basically uses the city of Houston as their playground, and basically occupies the floor of a hotel for a week. You know, again, providing a camping experience. And again, you know, we know parents love it. We know we also, you know, have virtual experiences, and these are of tremendous value. And we'll have to figure out as we go how to back to in person, how those continue. I certainly wanted to provide a resource at MD Anderson who can help with questions if you wanted to know about anything that we did on site. But I really don't want to take more time before going into the whole topic of survivorship and why these normalizing experiences are just so important. And so with that, thank you for listening to me. I'm going to turn this over to my colleague, Andy Livingston, who is going to go ahead and talk to you a bit more about survivorship as a field, and really give you a lot more of the factual basis of the science of that field. Thank you, Andy.
Great, thanks, Richard, and thank you so much to the conference organizers for the invitation to talk about a topic that is so important and central to what we do as oncologists, survivorship. It's really about thinking more than just getting beyond a cancer diagnosis and cancer treatment, and thinking about how can we assure that not only do these kids survive, but really thrive, to get back to normalcy and live happy, healthy, fulfilling lives for many years beyond that initial cancer experience. So with that, we can go forward. I think most here are familiar with pediatric cancers and the rarity of pediatric cancer. Overall, about 15,000 children are diagnosed with cancer in the United States each year, so far fewer than adult type cancers. And amongst those, the most common diagnosis is pediatric leukemia. It's about 2,000 to 3,000 cases in the United States. Next slide. When we think about extending that age group upward into adolescents and young adults, kind of a newer field and greater awareness of what's called AYA oncology, teens, 20s, and 30s, it actually is a larger patient population, as many as 75,000 cases a year. And we start to see the emergence of other types of cancers, some that are really prevalent in teenagers, things like testicular cancer, certain sarcomas, and thyroid cancer, and even some young adults being diagnosed with more adult type cancers like breast cancer or early onset colon cancer. Next. But if we look over time, you know, and this is data from what's called the SEER registry, what we really see through the 1970s, 80s, and 90s is that the incidence of pediatric cancer in the US has really stayed the same, about the same number of cases per year. And importantly, the mortality or the cure rates and survival of these cancers has continued to improve even to modern day. We see really dramatic improvements in things like leukemia, but improvements are more modest for certain cancers in childhood, like sarcomas and brain tumors. Next. But if we talk about the same time period that Dr. Gourley referred to, thinking about the advent of chemotherapy and the evolution of cancer treatments for kids, we really see some dramatic improvements. Even just in the past 50 years, if you were diagnosed as a kid with leukemia in the 60s and 70s, the majority of patients did not survive their illness. But we see these dramatic improvements now over that time period. And then sequentially through the 70s, 80s, 90s to today, where actually the vast majority of children will be cured of their cancer, 70 to 80%, and for diagnoses like pediatric ALL, more than 90%. And why is that? Well, a number of factors, really. We know that childhood cancers tend to be very sensitive to chemotherapy regimens because children can tolerate these chemos often better than older adults. It allows us to use multiple different types of treatments. Over these time periods, most kids are enrolled on clinical trials, which really allowed us to evolve the field and figure out what works, what doesn't, and how to build on each of those studies sequentially to improve outcomes. And so that's really what we can thank for kind of the current state of pediatric cancer care and high cure rates. Next. And so now if we look more recently at survival outcomes in the early 2000s compared to the 70s for both boys and girls diagnosed with cancer either as children or as teenagers, we really see across the board that there's been significant dramatic improvements in survival and cure. Next. So to summarize this first part of the talk, I shared with you that pediatric and even young adult cancers are rare, but fortunately, cure rates have improved dramatically over the past 50 years. And the majority of children who are diagnosed with cancer today will go on to be cured of their disease. But while some cancers in children have very high cure rates, more than 90%, outcomes for certain tumor types really haven't seen as much improvement and really remain opportunities for additional research so that we can improve outcomes for these children. So let's talk a little bit about what is survivorship and what are late effects of treatment. Strictly speaking, most studies, in the scientific world and research community, most of the time we talk about childhood cancer survivors as being any individual who was diagnosed with a cancer during infancy, childhood, or adolescence, who's living 5 years after the completion of their cancer treatment. But more practically, in modern terms, we've really begun to understand that survivorship begins at the time of diagnosis, that we really need to start thinking about the long-term outcomes and survival of these children from the day they're diagnosed. Next. So if we break this down by the numbers, I shared with you about 15,000 children are diagnosed in the US each year, and we can estimate about 75% of those kids go on to be cured of their disease. So go forward. Doing the math, that's about 10,000 new childhood cancer survivors each year. And if we think about that over the past 4 to 5 decades, that means that there's actually more than 400,000 childhood cancer survivors living in the United States currently. Or put another way, about 1 in every 450 adults in the US is actually a childhood cancer survivor. So I think most here and connected to this conference, of course, know and are connected in so many ways to childhood cancer survivors, but really all of us know someone who's a childhood cancer survivor when you think about how common this really is. Next. So what are late effects? Well, I think most of us are familiar with some of the short-term side effects associated with treatment like chemotherapy and radiation, things like fatigue, nausea, hair loss. But late effects is thinking about what are the potential long-term or chronic health effects that could be related to cancer or cancer treatment. Importantly, not just talking about the physical illness, but also the psychological complications that can come up, persist, or develop beyond cancer treatment, and that these effects are either secondary to the treatment itself or the cancer experience on the whole. And again, as this field evolves, we've really begun to understand that this is really not just talking about physical health, but really encompasses so many important domains for childhood cancer survivors, thinking about their mental health and psychosocial well-being, things like the financial health and reproductive implications of cancer treatment as a child, areas I'll go into further. So these late effects really mean long-lasting effects. Of course, kids are receiving treatment at this critical time in their physical, mental, and emotional development. And the timing of that exposure matters, of course, when the heart is developing, when the brain is developing, and the timing of things like chemotherapy and radiation can actually have more significant impact on kids long-term than we would even see in older adults. And importantly, these late effects don't go away unless we identify them, acknowledge them, and treat them. I'll go into some more specifics in the next part of the talk. So while pediatric cancers are rare, actually, childhood cancer survivors are much more prevalent in the US population. Late effects are these chronic illnesses that we think of as being secondary to cancer treatment that can come up many years after exposure. And these cancer-related, treatment-related effects can be long-lasting and even life-altering. So let's talk briefly about what are the long-term outcomes for childhood cancer survivors, and then move on to what I think is the most important part of the talk about how we can make things better for kids beyond their cancer diagnosis and treatment. So late effects are incredibly common amongst childhood cancer survivors. There's been a growing field and awareness of this, and a number of important research studies that really sought to understand what are the long-term health outcomes for kids after they finish their cancer treatment. Perhaps the biggest or most cited, perhaps most relevant study is this one here, led by Dr. Effinger and colleagues, called the Childhood Cancer Survivor Study, or the CCSS. And in this study, what they did is got a very large group of childhood cancer survivors, more than 10,000, and asked them about what are the health conditions they face as an adult and how does that compare to their siblings. And what we found out is that more than 2/3 of all childhood cancer survivors have at least one chronic illness. Many survivors are dealing with multiple medical issues, and 1/3 of all survivors have at least one illness that would be categorized as severe or even life-threatening. Next. So here, this table's from the same study. What you can see is when they compared childhood cancer survivors to their siblings, presumably a way to control for factors like genetics or exposure, or socioeconomic status. Of course, there was much higher rates of lifelong illness amongst childhood cancer survivors, things called grade 3 or grade 4, those being severe or life-threatening. And if you look at the bottom part here, more than 1/3 of childhood cancer survivors had more than 2 health conditions. Almost 25% were dealing with 3 or more chronic health conditions. And on the right side, this is broken down by the type of cancer in childhood. And we see that the rates are even higher amongst survivors of bone tumors like osteosarcoma or certain brain and spine tumors labeled CNS tumors here, but really can be seen across the spectrum of all childhood cancers. So I want to provide a few specific examples. One that gets a lot of attention and we think a lot about is talking about cardiac late effects. What does that mean? Really, what's the risk to heart health after going through cancer treatment? And we know that childhood cancer survivors are significantly more likely than their siblings to suffer with things like heart failure, heart attacks, or other heart-related issues called pericardial or valvular disease. And like most of these side effects, late effects, or long-term health effects, it can be related to the prior treatment, both chemotherapy and radiation. So in terms of heart disease, we see that certain chemotherapies called anthracyclines, medicines like doxorubicin, or what many would call the red devil, often used for treating childhood sarcomas as well as other cancers, can have a significant impact on heart health. And actually that the impact is dose dependent. So kids who got very high doses of these medicines in childhood are much more likely to have issues with heart health later on. And similarly, for patients who receive radiation, particularly if that radiation involves the chest or exposure to the heart, can also be associated with more heart problems later in life. So oftentimes radiation used for treatment of diseases like Hodgkin lymphoma, where patients used to get what's called mantle radiation, that practice has largely gone away based on the recognition that that type of radiation can really place patients at risk. And I think perhaps somewhat surprising actually is we know that childhood cancer survivors actually have higher risk of heart problems in their lives than other adults, even if they didn't receive these type of treatments. So it may not be specific to this type of anthracycline chemotherapy or radiation to the heart. Actually, any type of cancer treatment as a child is associated with having a higher risk of having heart problems as an adult. Next. Similarly, chemotherapy and radiation can affect lung function long-term. It's also related to the exposure or the type of treatment that patients receive. So radiation to the lung can be associated with something called lung fibrosis, or basically a scarring down of the lung long-term, where patients can have chronic cough or shortness of breath with exercising. This can also be seen with certain types of chemotherapy called bleomycin, used for testicular cancer as well as other types of cancers. And if we give those treatments together, actually, the risk of long-term side effects is even more. We think a lot about this as a developmental phase in terms of brain development, or what we call CNS toxicity, meaning the central nervous system. Various treatments can have a dramatic impact on the brain and spine. Of course, pediatric brain tumors are relatively common amongst pediatric cancer types, and very often we use radiation for the treatment of these brain tumors. But that radiation can have a number of side effects, including what's called endocrinopathies, basically problems with hormone levels and the pituitary gland, sometimes secondary malignancies, meaning a cancer that comes up later in life related to the prior treatment, as well as decline not only in physical function, but in cognition, which maybe isn't surprising when you think about exposing a developing brain to radiation. And really, these effects are incredibly time dependent, and we know that getting radiation for very young children has the most dramatic impact. So in one study that looked at this, they found that IQ scores go down for children after they receive any radiation to the brain, and actually that continues to go down year by year after the completion of treatment. On the bottom graph, in that study, they were looking at what about the timing of radiation? And interestingly, children who received brain radiation prior to 7 years of age saw the decline or the sloping line in their IQ, but actually older children didn't have much as significant of an impact in terms of IQ scores and cognition. One area that we're thinking more about and getting more information about is about fertility. Particularly for children who are diagnosed in adolescence, there can be significant impacts later on in life in terms of fertility and infertility. So both boys and girls, or men and women, I should say, who are survivors of childhood cancer are actually much less likely to become pregnant or to father children later in life. For young men, the risk factors for infertility or sterility are things like a younger age at the time of diagnosis, exposure to certain types of chemotherapy we call alkylating agents, and of course, testicular radiation as well. For young girls or young women, it's a little bit different actually. Older age at the time of cancer treatment is associated with more issues, particularly thinking about girls who are post-pubertal, and then radiation to the brain, which can affect hormone levels, radiation to the ovaries, or these alkylating agents can really create a number of issues in terms of fertility or premature menopause. But the late effects of cancer treatment really extend well beyond the physical health and well-being to impact so many other areas of life. And this is where I think we really are starting to understand more completely a holistic approach to survivorship care. Of course, as a physician, as an oncologist, I'm very focused on these health-related side effects, but now we know we really need to extend that to think about the psychosocial well-being for these teens, young adults, as they grow into adulthood. Compared to their siblings, childhood cancer survivors are less likely to be insured and to have health insurance, less likely to get married, less likely to hold down a steady job or live independently. So in one study that looked at employment, we see that compared to age-matched siblings who are more than 95% had a job or were employed over a 1-year period, that was lower across all childhood cancer survivors, and perhaps not surprisingly lowest amongst survivors of brain tumors. In another study looking at the financial impacts of cancer, we know that when cancer care is associated with a high out-of-pocket cost compared to household income, this can really have lifelong impact in terms of being able to pay medical bills, needing to borrow money, or being uninsured or underinsured. And this can really have a number of health impact, because oftentimes these patients reported that they would defer seeking medical care, that they wouldn't take medicines as they were prescribed because it was too expensive, so they try to space out their medicines. But it can even go beyond that, where we know that survivors, childhood cancer survivors, are also at higher risk of even being able to pay for basic things like food and housing. So we really need to change our view of all the impacts that going through cancer as a child can have lifelong. Next. Another phenomena we see is something called frailty. So this is probably a term you're familiar with in general, but probably associate with older adults, perhaps people in their 70s or 80s, or not thinking of that as teens and young adults. So in medical terms, what is frailty? Well, what we're really talking about is things like low muscle mass, exhaustion, low energy, slow walking, and weakness. And something called pre-frailty if patients have more than two or more of these conditions. So in the US, about 10% of adults over age 65 meet this medical definition of frailty. And why does that matter? Well, we know that frailty is associated with a number of poor health outcomes and things like early death or mortality because of that physical weakness and low muscle mass, et cetera. But I think really surprising to me and others in the field is when we looked at this across pediatric cancer survivors, we found out that actually a high proportion, 13% of childhood cancer survivors have frailty, and almost a third met the definition of pre-frailty. And here we're talking about an age group where the average was in their 30s. So a time where most of us would think about being near kind of peak physical health, we're seeing this effect, which is really almost accelerated aging because of the overall impacts to the body of going through chemotherapy and radiation treatments as a child. Importantly, exercise and physical fitness play a huge role. We know that childhood cancer survivors report that they're much more likely to be sedentary or lead sedentary lifestyles, despite all that I've shared and all we know about the risk of late effects, and that this can be higher for certain cancer types. So patients who are survivors of bone sarcomas like osteosarcoma, brain tumors like medulloblastomas are much more likely to report an inactive lifestyle. And overall, we see that teens and young adults who are childhood cancer survivors are much more likely to face issues with obesity and metabolism, higher risk for high cholesterol and diabetes. So we really want to start thinking about what are the ways we can incorporate activity, exercise, and physical fitness in part of cancer care. And long term, we know that these survivors continue to face issues. Despite getting past cancer, being cured of cancer, being alive without cancer beyond the diagnosis, unfortunately, childhood cancer survivors continue to face a higher mortality or risk of death compared to the general population. You can see that in graph A here, where the yellow line is the general US population, and the blue line shows childhood cancer survivors, even 5 years beyond their diagnosis and up to 30 years later, are still at higher risk of death. And why is that? Well, the good news is with all the improvements in cancer care, we see that survival rates from cancer are much higher, which means there's far less incidence of what we call recurrence, or basically the cancer they faced as a child coming back. But the trade-off of some of this has been higher rates of secondary malignancies, developing another cancer related to the treatment, or issues like related to heart or lung health, some of the things I already highlighted. So clearly we need to do better in thinking about how do these survivors do beyond their cancer treatment so that they can live long, healthy, and productive lives. Next. So late effects are very common and can occur in any organ system. And despite improving cure rates, we still see compromised long-term outcomes really related to these health effects. And so we need to start developing treatment plans for children with cancer that consider this from day one. This is where there's a huge opportunity and where our field is going. How can we decrease the toxicity, those side effects in the short and long term, so that we can improve the health and wellness for childhood cancer survivors? And really, it's a balance. You know, as Dr. Gourley shared, and I as well, so much of pediatric oncology at its inception and development of chemotherapy was incredibly focused on improving cures. Of course, that has been the #1 goal of pediatric oncologists, is to cure more kids with cancer. But as we drive those cure rates very high and more than 90%, we need to start figuring out what's the balance between adding more treatment, more chemo, more radiation relative to cure, but also trying to decrease those long-term side effects or late effects of treatment. And there's really a number of strategies that oncologists have undertaken to do that, whether it's reducing the amount of a certain exposure or drug, providing certain medicines to protect from the long-term side effects, or even developing specialized programs where we can screen and evaluate patients to see, are they at risk of developing these long-term or late effects of their treatment. For example, when we talk about heart health, some of the more recent strategies are to limit the amount of doxorubicin, that red chemotherapy, anthracycline chemotherapy that a patient receives in their lifetime. Sometimes giving medicines that protect the heart, an FDA-approved drug called desrizoxane or Zinacard that can help protect the heart from these effects, and really reducing or eliminating radiation to the heart when possible. Next. In terms, there's other strategies also going forward where we're thinking about, can we look at patients who are at high risk and reduce their risk after their treatment? So one example is this study being run by the Children's Oncology Group, where patients who receive that anthracycline chemotherapy are randomized to receive a heart protective medicine called carvedilol or not, and then seeing as we go forward, does that reduce the likelihood of developing heart problems? In terms of brain health, certainly we want to try to decrease the use of radiation for young children. For children being treated for leukemias, we've really gone away from what's called craniospinal radiation to using intrathecal chemotherapy as a way to avoid radiation. And more recently, there's modern radiation techniques called proton therapy that allows a radiation oncologist to more specifically target the brain tumor while reducing the amount of radiation exposure to other parts of the brain, which we hope will reduce long-term effects or side effects of the treatment. Similarly, other types of treatment for Hodgkin's lymphoma, we look to eliminate radiation treatments for patients who respond well to chemotherapy. There may be patients who don't need radiation at all. Next slide. And we try to eliminate the drugs that we know are most toxic. For example, removing the drug bleomycin from this regimen with a modern drug called brentuximab to reduce the chances of long-term effects on the lung. Next. In terms of fertility, there's not as much that we can do past treatment. So it's really a focus on addressing fertility concerns prior to starting treatment. So we know for young men, having a specific conversation and counseling them about the risk of infertility is key and really provides the opportunities for teenagers and young adults to do sperm banking prior to treatment. Similarly, for young women, where there are more and more options now in terms of trying to preserve fertility, whether that's freezing eggs or using experimental approaches to freeze ovarian tissue so that those young women may go on to be pregnant later in life. Next. And critically important is encouraging exercise and physical fitness. So as we look across cancer types, we have seen that there is a number of benefits for exercise in cancer survivors. Perhaps surprising or maybe not, is actually increased exercise and physical fitness has been shown to improve survival, decrease the chance of cancer coming back, and prevent many of these late effects we've been talking about. Certainly things about physical fitness, metabolism, and obesity, improving cardiovascular health, but also improving things like psychologic distress and cognition. But we know there's actually several barriers that prevent or impair children and young adults from pursuing regular exercise. So this is one small pilot study published earlier this year out of Roswell Park that I thought was particularly interesting and relevant. They took a group of teens and young adults who are cancer survivors and looked at what are the barriers they face to exercising. They provided education on exercise and nutrition, and they found that this kind of education really helped to overcome some of these barriers about worry and willpower, about accountability, and it was overall very successful. And I thought the conclusion here by the authors was really great and tells us where we need to go. You know, given the short and long-term impacts of cancer and its treatment, and the benefits of physical activity and exercise, like this one provided with social support, these programs should really be considered adjuvant therapy for young adult cancer survivors, really saying this should start to become the standard. From day one or early on in treatment and post-treatment, we really need to start thinking about diet and exercise as a key means to improve outcomes. Next. And the good news is that these outcomes really are improving. So if we look at some of the same data, the updated data from that childhood cancer survivor study, we see that patients are continuing to do better and better and live longer, 1970s, 80s, and 90s. And that's a trend that even continues to this day. It's for two reasons, actually. One is that we see less and less recurrence, meaning that survival and cure rates continue to improve, which is a huge success. But also with some of the strategies I've highlighted here, we're also reducing the likelihood of some of these long-term health-related complications and improving overall survival for these childhood cancer survivors. Next. And the same is true for teens and young adults over the same time period. In this study we did here at MD Anderson, we saw that long-term survival is continuing to increase even into the 2000s. Next. So, recently there's been a number of efforts to decrease late effects, which we hope will improve outcomes, but not without compromising high cure rates, decreasing exposure to toxic agents, using protective medicines and supportive care, early screening and treatment of these late effects, and improving the ways we give treatment. And when we do that, some of these things have already shown that we can improve the long-term outcomes for childhood cancer survivors. In the last part of the talk, I want to highlight the role of specialized programs that can really improve outcomes for childhood cancer survivors. So first is talking about camps, of course. I think most here are very familiar from various experiences and firsthand experiences about the number of benefits of camps for children with cancer. But here's some of the data to back that up. In two studies, actually this was looking at across multiple studies now published in the medical literature, we see that there are so many positive benefits for children participating in summer camps. Of course, things like social support, improvement in quality of life and psychosocial functioning. We see improved confidence and self-esteem. But even beyond some of these psychosocial outcomes, we know that going to camp can actually improve physical activity, not only during camp, but after the camp experience. And on the right, a separate study looking at the psychosocial well-being of children who attended these camps identified some very important domains, things like improving mental health, social health, and really getting to that idea of normalcy for children with cancer and childhood cancer survivors. Next. And the benefit of camp, as I touched on, actually extends beyond mental health and socialization. We know that these camps can be really important in changing lifestyle and physical fitness. So in one study looking at adolescents who attended outdoor adventure camps or summer camps, we saw that this really significantly increased their physical activity level, of course, during camp, but importantly, that can encourage lifestyle changes that extend beyond that week at camp. In one study, they tracked physical activity using Fitbit type monitors and found that teens with cancer at these camps were getting more than 18,000 steps a day. So I don't know how many people here track their steps, but I have hard enough time getting anywhere near 10,000. So 18,000 is pretty impressive. And while they were improving their activity, actually they didn't report higher rates of fatigue. So just again, another opportunity to encourage these healthy behaviors amongst children and cancer survivors. Next. Here at MD Anderson, we've developed a number of specialized programs to really focus in on this group to try to provide the support needed to ensure long-term success. One is the Childhood Cancer Survivorship Program, and the second is a program I'm particularly proud of, what we call the MD Anderson Adolescent and Young Adult, or AYA program. And you can see our group here, or a fraction of our group here at the ribbon cutting for our new clinic. But what is the purpose? What are we seeking to do? Really, it's about how can we improve patient experiences, quality of life, and the long-term survival for teens and young adults. And how do we do that? We want to provide this age-appropriate setting, the psychosocial and supportive care they need to really be successful. And I'll go into that in some more detail. This program is actually pretty broad and far-reaching within the institution. In addition to the clinic, We partner with a very multidisciplinary team, social workers. We have psychologists who are vocational counselors thinking about how does cancer diagnosis and treatment impact things like school and career choice, nutrition, genetic counseling, school and creative arts. And we've been able to extend this program beyond the hospital itself by adding a young adult support group. Now that meets via Zoom. We have a young adult advisory council where young adults tell us about, what's the support they need and really guide our programming. We have been fortunate to put together a young adult wellness retreat with the philanthropic support of Kendra Scott and her group. So really just trying to extend and create this social network of teens and young adults who are cancer survivors. And also it's a huge opportunity for us to push the field forward with research and understanding what are the needs and how do we improve outcomes for this patient population. Next. So when patients come to our clinic, there's really 4 key areas we tap into. This clinic works in conjunction with the oncology team. So we don't take over the patient's primary cancer care, but really say, what are the ways we can support teens and young adults as they go through their treatment and getting back to normalcy beyond their cancer treatment. So for us, that's looking at things like psychosocial support, meeting with our social worker and vocational counselor. Of course, it's a very transitional time where patients may be going to college or moving out of the house, developing more independence. And thinking about how does cancer impact that and impact relationships. The second piece is fertility, counseling patients about what's the impact or potential impact on future fertility and help it to facilitate things like sperm banking. Genetic predisposition. So, why does a person get cancer as a child, teen, or young adult? Really understanding, is it something that's inherited? Is it something that could be passed on? Is it something that could put a patient at higher risk for developing other cancers later in life? And then lastly, of course, is the survivorship piece, understanding that, when you finish cancer treatment, that's really not the end of your treatment. That's the beginning. And we need to continue to follow these patients long-term to really reduce those long-term health complications that I've highlighted in the talk. Next. So really what we've developed is a comprehensive model trying to figure out what are all the different ways that going through cancer treatment and being a cancer survivor can impact life. And here's just some examples of that. Things like finances, insurance, diet and exercise, body image, relationships, intimacy and sexuality, and also, of course, symptoms, supportive care, and late effects of treatment. Next. And so lastly, I just wanted to share with you a quick snapshot of what our clinic waiting room space looks like. Actually, this space was designed fully by young adults who are cancer survivors here at our institution. Here's the waiting room where they said, look, I don't want to feel like I'm in the hospital. I want to feel like I'm sitting in my living room, hanging out and meeting other young people who are going through the same experience. So it's really been a cool opportunity to develop a special program to really support teens and young adults going through cancer treatment. Next. So in conclusion, we can go through these. Pediatric cancers are rare, but childhood cancer survivors are relatively common. We know that the late effects are frequent and really go beyond physical health to impact mental health and social well-being. We're undertaking a number of different strategies to really improve these long-term outcomes, really by thinking about survivorship from the time of diagnosis. And specialized programs can be really critical in terms of monitoring for treatment-related medical conditions, promoting mental health, providing that key psychosocial support, and enhancing physical activity. And that's really how we go forward in terms of improving health, wellness, and productivity for these childhood cancer survivors. Thank you, and I'd be happy to take any questions.
So thank you so much for listening to us. And thank you, Andy, for providing the informative portion of this talk.
There are a couple of questions for you guys in the chat. Would you like me to read them to you?
I think I can read this one for Andy. So what is the ballpark percentage difference in survival by adjusting toxicity of the more common treatments? How do you convince a parent who wants their child to have the highest possible chances for survival?
Yeah, so this is a really great question, and I think it hits the nail on the head. First and foremost, the goal of our treatments are to cure kids of their cancer, because you don't get to talk about long-term effects if you're not surviving that cancer. Not just 5 years after diagnosis, but 55 years after diagnosis. So actually, the way we've gone about it more broadly in oncology is actually to try to understand which patients are at the highest risk from their cancer. And those kids, we don't adjust or reduce the treatments. But we know there's some patients who are actually at a very high chance of cure and a low risk of the cancer coming back. And those are the opportunities where we can say, maybe we can give less chemotherapy, maybe we can avoid radiation. And this is actually something that we study in clinical trials to say, is this treatment where we leave out radiation as effective? And so now we've been doing this long enough that there's several studies that help tell us, okay, yes, you can avoid these treatments, but still have very good survival outcomes. So it's an important balance, but it's of course something that we've approached as a pediatric oncology community. It's something that we answer in the context of clinical trials. So we have that data to talk to parents to say, you know what, reducing the treatment is appropriate and wouldn't reduce the chance of cure.
And a couple of additions to that are the changes are made slowly so that we do this stepwise and, change things very little so that we don't compromise, the chance of cure, and then do it stepwise and sequentially. And sometimes they're swapping. I think one of Andy's great examples was the, brentuximab for bleomycin. Brentuximab is a drug, probably works a lot better than bleomycin. Brentuximab, if I had to guess, was invented probably, 5 to 10 years ago, whereas bleomycin was invented 50 years ago. And it's just a better choice. And obviously, keeping a chemotherapy that starts with a B, they didn't even have to change the initials for the chemotherapy regimen. That's just a little bit of a humor, but really it's swapping sometimes or delaying so that the side effects are less, but no big changes. The next question, when it comes to the lack of insurance for pediatric cancer survivors, is because they've reached their limit for what insurance will pay. Insurance companies won't insure them because of health history or low employment rates. I'm going to try to answer this first, and I think it's more the latter too. So if you look at relative employment of cancer survivors as compared to their siblings, they actually have a lower like educational attainment. They have lower incomes and lower overall employment rates. As most folks in America have insurance through their workplace, that's going to immediately transmit into sort of differences. Again, we never want to get political. Some of these studies were done pre the Affordable Care Act. The Affordable Care Act's provisions around not denying folks medical insurance based on prior medical conditions have actually been helpful. I am aware of a publication coming from somebody in our group who actually talks about the benefits of outcomes in AYA patients, related to the advent of the Affordable Care Act. But prior to that, insurance companies were able to create pre-existing condition clauses. I will state out loud my belief that insurance companies should not be allowed to deny folks based on pre-existing conditions. I think that's critical for our cancer patients, regardless of how that's managed and how that happens. I don't know, Andy, do you have anything to add on this one?
I agree completely. Yeah, as you mentioned, Richard, we did a recent study here looking at the impact of the Affordable Care Act, and And really, by providing more access to insurance, we know it can really improve outcomes for young adults who are childhood cancer survivors. So some of that has to do with, as children, most are, of course, are on their parents' insurance. As that age is extended upward as part of the Affordable Care Act, that's been helpful because kids could remain on parents' insurance longer, usually up till age 25. And then, being able to have some type of affordable health insurance beyond that is really the key. Yeah.
All right, and a question from Beverly T. I'm going to send this one to Andy. Do you think there will ever be a time when neither chemotherapy nor radiation will be used for treatment, like totally non-toxic treatments? Is that the goal?
I think every oncologist would love to see that. I mean, I think we're all hopeful that we can get beyond some of the treatments, again, that have been around since the 1950s. But I think if I'm realistic, we will continue to need these type of treatments in some form. But the examples of how it's improving is things like proton radiation. Now, using very sophisticated technology, in certain cases, we can use a much more targeted type of radiation that can reduce some of those side effects. And on the chemotherapy side, we're seeing evolution of other treatments, things called immunotherapies, or sometimes targeted therapies that work on cancer genetics to try to be more specific in the treatment. Now, these treatments aren't without side effects, but it is kind of an evolution of the field where we see how can we make the most effective treatments with the least side effects.
So a question from Rich B. You mentioned the studies and impact of camp on the health and wellness. Will there be any studies on the virtual programs that have grown now due to COVID? As a camp guy, what's your thoughts on the impact and potential impact of virtual programs? I think we're all, with COVID, adapting very quickly to a changed world so influenced by virtual programming. We would have never thought as healthcare providers that we would do as many visits as we do virtually now. That's become part of our practice. And to some extent, there's a lot of benefit. Some of the benefits are, when we look at our lectures, more people attend because, it's not as hard to get there. Your reach goes beyond your regional area. On the other hand, there are downsides, meaning, I think, Dr. Livingston highlighted well, the real value of camp is the amount of exercise that physically occurs at camp. And while I know virtual activities can have people do activities in place, I'm not convinced that will entirely simulate a baseball field or soccer field or any of the other activities we do at camp. So there's trade-offs. I do hope in the future we embrace both platforms, that we go back to, there is a reason for a soccer field, but we don't abandon the virtual side of things because, there was a lot of benefit there also. I don't know, Andy, you're younger than I am, so maybe you have even more perspective on this. Maybe you don't think we need a soccer field anymore?
Well, no, I certainly think there's a huge benefit to being together in person in the same place. I mean, there's just things you do at camp that it's very hard to accomplish in the virtual world. But I totally agree. There is an opportunity there. We've seen, especially amongst teens, there's a huge uptake in virtual programming, even if it's just that psychosocial connection and well-being piece. So, like when we moved our support group to being a Zoom-based young adult support group, wow, attendance there really went up. So, similarly, we can do other activities in kind of this hybrid model. I think there's definitely a way to engage people there. So perhaps one of the big advantages of doing more virtual programming is really getting access to more kids, teens, and young adults who wouldn't be able to access camp otherwise, to really bring them into some of this experience. But I certainly don't think it's going to replace camp by any means.
Can you speak to your work regarding improving educational opportunities for children who are displaying cognitive challenges due to their intense cancer treatment? At MD Anderson, we're really proud that we have a 4 psychologist group that's part of the team Two of those psychologists are neuropsychologists. They tie into a fully accredited school that operates on the hospital campus. A lot of what they do is create personalized education plans, meaning, kids who are having cognitive difficulties, which can be around attention or math or specific areas, through specific educational interventions, they can overcome those challenges. A lot of that, really sort of, we don't have the longest term follow-up on, but we're hoping those type of things will help. In the last second half, there have been studies examining activities such as art, meditation, yoga on improving late effects. This could be along with physical exercise or separately. Absolutely. Huge supportive program in pediatrics that embodies all of the sort of approaches to, the complementary side of care. So, mindfulness, acupuncture, yoga, et cetera, et cetera. That tends to be separate from exercise, where we have actually a lot of clinical trials studying the impact specifically on exercise in sort of leading to better lifelong behaviors. Actually, one of the lounges at MD Anderson has been converted to a gym as a means of trying to promote physical fitness. So a lot is going in this area, and obviously everything is embraced. We are at time, so thank you guys very much for listening. We really appreciate the opportunity to speak with you, and thank you for all your great work. Obviously, it's phenomenal that our patients have these opportunities to go to camps, and obviously we love working with you guys. Thank you.
Thank you.